Dear committee members, dear audience, let me present my 9-month progress on the PhD thesis of New Frontiers in the Diagnosis and Management of Cutaneous Malignancies. I am Lili, Gulyás, a medical doctor and a PhD student at the Department of Dermatology at Semmelweis University, and my supervisors are Kenda Lőrinc and András Bámvölgyi. Let me introduce you to my vision, which is improving the diagnosis and management of cutaneous malignancies. And to achieve this vision, my mission is to identify the most effective serological biomarkers and treatment options. Currently, I have 2 ongoing projects, and let me talk about my first project, which is investigating the predictive value of different biomarkers for post-diagnostic events in cutaneous malignant melanoma with the methodology of a systemic review and a meta-analysis. Cutaneous melanoma is the 5th most common malignancy among the US, and we can say that the 5-year survival can vary between 98 to 22% depending on the primary tumor stage, and every 1 out of 3 of all melanoma patients will have a disease recurrence. Unfortunately, in the clinical practice, there are no serological biomarkers with relevant predictive values are available. Of course, we use some biomarkers like LDH and S100B to monitor the patient, but they have low predictive value. And in the past few years, some promising novel biomarkers appeared with a potentially higher predictive value to help the therapeutic decision and monitor these patients. Therefore, our aim is to compare the predictive value of serum biomarkers in melanoma patients to predict disease progression and patient survival. So the clinical question is, which biomarkers have the highest predictive value of patient survival in melanoma patients? We use the PEO framework, where we'd like to compare different serum biomarkers in melanoma patients in the outcome of death, disease progression, and patient survival. And we hypothesize that novel serum biomarkers have higher predictive value for the prediction of survival in melanoma patients. Here you can see my final search key and the date of the systemic search. And you can also see the flowchart of the selection. In the end of this process, I have 217 eligible full text. Here you can see my outcomes, which is all related to patient survival. And there are ongoing analyses from different types of survivals. And I'd like to present the results on overall survival and different serum biomarker level associations. In this slide, you can see a forest plot of overall survival and different serum biomarker level associations. Here you can see pooled hazard ratios in each biomarker subgroup. And the hazard ratios express the probability of an event happening, in this case, patient survival. Let me highlight the 2 currently used serum biomarkers in the clinical practice. In the case of S100B, the 2.2 hazard ratio means that patients with elevated levels of this biomarker has 2 times less chance to survive than those with the lower biomarker levels. And in the case of LDH, it's a 1.69 hazard ratio. But if we look at these results in a different point of view, in different therapy subgroups, we can see that in the case of LDH, in the targeted therapy group, the LDH didn't perform well, and it's also not reached the statistical significance. But in the immunotherapy group and in the case of other therapies, it reached the statistical significance level. In the case of S100B, it's an interesting result that unfortunately, I can't present this forest plot, but among all the immune checkpoint inhibitor groups of biomarkers, it reached the highest hazard ratio with a 3.74 unit. But it didn't reach the statistical significance. However, it can be clinically relevant. And another interesting result that if we observe the circulating tumor DNA levels in the targeted therapy treated patients, we can see that the patients with detectable levels of circulating tumor DNA had 2 times less chance to survive than those with undetectable levels. So I'd like to highlight the strengths and the limitations of this study. It's a widely comprehensive analysis on the literature, and these are objective measurements. And in the future, it could help monitoring the therapy and predict the patient's survival. But it has limitations too, that in the case of biomarkers like interleukin-6, the cutoff values are not always the same, and the study types are different. So based on these results, we can conclude that in different therapy groups, there are differences about the biomarker's ability to predict patient survival. And the implication for practice, it could be that in the immunotherapy group, the S100B is still the best biomarker. However, it was not statistically significant. And the LDH predicts well in the immunotherapy, but not in the targeted therapy treated patients. And the implication for research could be that there are biomarkers that are worth further investigation, and unified cutoff values are needed in the studies. Here you can see the progress of my first project, and I'm currently doing the risk of bias assessment. Let me briefly introduce you my second project, which is investigating the safety and efficacy of systemic therapies in locally advanced or metastatic basal cell carcinoma patients with the methodology of a systemic review and a meta-analysis. Basal cell carcinoma is the most common malignancy in Caucasian population, and it can be treated successfully through various surgical or non-surgical procedures in the majority of the cases. However, in some cases, these lesions have progressed to a point where these traditional treatment options are no longer feasible. These lesions can cause disfigurement and also intracranial penetration, affecting not only the physical appearance of the patient, but also their quality of life and potentially even life expectancy. For these advanced cases, there are some novel systemic therapies are available, like sonic hedgehog inhibitors and PD-1 inhibitors. Therefore, our aim is to assess the therapeutic efficacy and safety of systemic therapies in this patient population. So our clinical question is, are PD-1 inhibitors effective for patients who fail to respond to sonic hedgehog inhibitor therapy? Our patient population are locally advanced and metastatic basal cell carcinoma patients, and we'd like to compare sonic hedgehog inhibitors to PD-1 inhibitors in the outcome of efficacy and safety. And we hypothesize that in these patient populations, PD-1 inhibitors are an effective and safe therapeutic options after failing the first-line systemic treatment. And the clinical and research implication would be to find the most effective and safe systemic therapy for this patient population after failing the first-line systemic treatment. Here you can see a preliminary research case which I'm currently working on. And to summarize, I have two ongoing projects related to dermato-oncology, and I plan to submit them in this year. And I'd like to thank you for your attention with a great quote from the great movie Star Wars: "Do or do not, and there is no try."
Yeah, congratulations. My question would be that do you plan to perform subgroup analysis based on the melanoma stages?
Thank you for your question. It's a very good question. We'd like to, but in the case of overall survival, we can do this because in every study there are stage 3 or 4 patients, but I think in the relapse-free survival group we will be doing a subgroup analysis based on the stages too.
Thank you.
Okay, so it was very interesting for me what you emphasized, that in the different therapeutic groups you find different results. Can you explain it anyhow?
I thought about it a lot, and it's only a theoretical thing. I didn't highlight that, but I think I can go back. So in this forest plot, we can see some different biomarkers like neutrophil to lymphocyte ratio and derived neutrophil to lymphocyte ratio. And a lot of articles observe that in the immunotherapy treated patients, regulations in the immune system, in the patients itself. So it may lead to individuals' patient follow-up in the immunotherapeutic groups, because the drugs also affect the immune system too.
Mm-hmm. And do you examine patients without any therapy as well?
Yes, but in this outcome there were few patients with stage 1 or 2 early stage who got only therapy, but in the progression-free survival group there will be some surgical groups who didn't get any systemic treatment, so it would be very interesting to see the results, yes.